alpha glucosidase inhibitors. So this is the Voglibose available in the market. OD or BD or TID? Not OD, not BD, anything. Okay, OD or BD or TID. So how it acts? It inhibits the absorption. So depending on the, it inhibits the absorption of the carbohydrates from the intestines. See, this is the brush border of the cells, alpha glucosidase inhibitors. See the duodenum and the jejunum and the ileum. See the with the acarose, the red one. So without these tablets, the blood sugars will go up. So with that, the red line, that means hyperglycemia will not be there. Postprandial hyperglycemia will not be there. So are they good drugs or bad drugs? How much reduction will be there? Because it controls only postprandial hyperglycemia, not the fasting hyperglycemia. Okay. To get that 1 to 1.5 or 1.5 to 2, you have to get both fasting and PP controls. Here they reduce only postprandial. Thiazolidinediones. What is the example? Good, pioglitazone. See the GUT4 mechanism. In the sulfonylureas, do you have the receptor there? What is the name that is a receptor? Sulfonylurea receptor, SUR. So this is the GLUT4 here. They are the SUR receptors, sulfonylurea receptor. Here the GLUT4 receptors are there. How they act? PPR gamma. So they reduce the hyperglycemia here. So activator of the PPR valve enhance the sensitivity to the insulin, so that they almost like a insulin sensitizers. There are two insulin sensitizers. One is metformin, the second one is pioglitazone. There are two drugs which act on the insulin resistance. What are they? Metformin, pioglitazone. Insulin resistance. So metformin, 60 to 70% they act on the liver, and the remaining 20 to 30% they act on the muscle and adipose tissue. Whereas pioglitazone, 60% act on the muscle and adipose tissue, whereas 30% act on the liver. Am I clear? So both the drugs will act against insulin resistance. Both will improve your insulin sensitivity. Metformin more action on the liver, less action on the muscle and adipose tissue, whereas pioglitazone more active in muscle and adipose tissue and then active on liver. So side effects already told you. So weight gain, fluid overload, heart failure, pedal edema, fractures, osteoporosis, anemia, that is mild lowering the hematocrit, increase the risk of the macular edema, and increase the risk of the carcinoma bladder. Now the only thiazolidinediones available in India is pioglitazone. What is the different strengths? Already I told you. So India, we have the advantage of 7.5 mg. Even our Indian population, 7.5 mg also gives you good results. What is the reduction of the HbA1c? So 0.5 to 1.5, not even 1.5, maybe 1.2. See the advantage, pioglitazone has favorable effects on the lipid profile. So contraindications in heart failure, because it causes pedal edema, so fluid overload, so better to avoid in heart failure. Pregnancy, all drugs are contraindicated except two. One is metformin, the second one is glibenclamide. Not all other sulfonylureas, only glibenclamide, because that does not cross the placental barrier. See, avoided in the renal insufficiency. What other drugs will avoid in the renal insufficiency? Metformin. When the GFR is less than, you should remember 30 and 60. More than 60, usual dose. Less than 30, don't use. 30 to 60. Use with caution anemia, because pioglitazone will cause anemia, etc. Same things here. So contraindications. Here the female, 56-year-old lady, type 2 diabetes for the last few months, on lifestyle modification and the metformin, 1000 milligrams a day. She comes to the hospital for a follow-up visit. Weight has reduced from 78 to 76. Height 158. A1C 8.9 to 7.9. What will be the further line of the management? Good question. What is the working diagnosis? So working diagnosis here is diabetes plus obesity. Okay. Then the diabetes is type 2 diabetes. She is on metformin. What is the dose? 1000 milligrams a day. Okay, came for the follow-up. Is there any reduction of the body weight is there? Yes, 2 kgs. Are you happy with 2 kgs? So a further reduction. What is their ideal body weight? 158 minus 100. So 58, maybe 60 or 62. So still 10 to 15 kgs weight loss is expected here. Is the HbA1c at the target level? No. So earlier nearly 9, now it is nearly 8. So our target is 6.5 or the 6. So how to reduce it? So you have a lot of options. You can use sulfonylureas, you can use voglibose, you can use the pioglitazone, you can use the gliptins, or you can use the SGLT inhibitors or other drugs also. So here you need a drug which can reduce the HbA1c, which can reduce the body weight. These two are very important here. So what drug you prescribe? So patient can afford injectable semaglutide, so that will help you in reducing the body weight and also the blood sugar. Suppose if the patient is not interested in the injectable therapy, parenteral, and can't afford, so how? So metformin plus something else. What? So first step, metformin increase the maximum dose, getting only 1000 milligrams. We can go up to, so 2 grams or 2.5 grams or 3 grams also, depending on the obesity. But at least you can go up to the 1500 mg to 2 grams here. So instead of the 500 milligrams BD, you can go up to the 500 milligrams TID or 500, 1000. That is 2 grams. Okay, number 1. So by increasing the 500 milligrams of the metformin, can you reduce the HbA1c by from 8 to 6? Not possible. Not possible. Okay. So then what other drug to be started? The drug should not increase the body weight. It should be either weight neutral or weight reducing drug. So in that way, sulfonylureas can you use? No. Repaglanda can be used? No. Pioglitazone can be used in a female, perimenopausal, osteoporosis, body weight, etc. No. Can you use the voglibose? Yes, you can use. But what about the HbA1c reduction? It is only mild drug, 0.5 to 0.6%. So it is not possible to reach your target. So what other drugs are there in your hand? Gliptins and SGLT2 inhibitors. So that is how you have to improve your concept of diabetology. Okay. So there is no shortcuts in learning. So you have to maintain, you have to learn the concepts in the management of the hyperglycemia. Yeah, am I clear? Now we will go to the incretin mimetics. So how the incretin acts? I told you the omnious octet. So incretins will act on the 5 ways. What are they? I told you the 8 ways of getting hyperglycemia, no? Alpha cell, beta cell, intestines, liver, kidney, muscle, adipose tissue, brain, etc. So these incretins will act on how many ways? Out of the 8, how many ways? Suppose for example sulfonylureas. Sulfonylureas, how they act? Out of these 8 ways, where they attack? Pancreas. Your beta cells or alpha cells? Yes. So by using the sulfonylureas, they attack 1 out of these 8 parameters. What is that? Beta cell of pancreas. Okay. You are using the voglibose. Where they act? Only on only one target. That is the intestines. Okay. Suppose you are using the metformin. So where they act? 3 parameters. Liver, muscle, adipose. Very good. Suppose you are using the pioglitazone. Where they act? Pioglitazone. Pio. Again the same metformin. Muscle, adipose tissue and the liver. The difference is metformin more on the liver, less on the muscle and adipose tissue. Pioglitazone more on the muscle and adipose tissue and then the liver. Okay. Now ingredients. So in such way, how many ways they act? Am I clear? Tell me. So 3 ways. Okay, GIT, pancreas. So there are the 5 ways of getting used in these things. One is alpha cells, beta cells, intestines, brain, and also the liver. So in that way, these drugs will act. So that is the ingredient hormones. These are the only drugs which act on the alpha cells. No other drugs will act on the alpha. How it is important? Alpha cells. Okay. So by acting on the alpha cells, how they act? They reduce the glucagon activity or they increase the glucagon activity? Your sulfuridas, maglitide, glucose, the same thing. Same wherever they act on the beta cells, the same picture here. So this I already told you. What is this effect? Incretin effect. See here the first one. First one is glucose. Okay, your blood glucose. The second one is incretin effect. Oral glucose causes more of incretin release. This is incretins. See, first one is where? Bread and omelette, bread and jam. So that means immediately by seeing the food, your salivation will occur, and immediately after salivation that gives signals to the intestines. See, food, saliva, straight away to intestines. What you have? You have incretin hormones. What are they? GLP-1 and GIP. So release of the gut hormones. They are the incretins. So activate the GLP-1 and GIP. Are they good for us or not? Good, because they act on the 5 ways. They reduce the beta cells. They increase the they reduce the alpha cells activity. They increases the insulin levels. They act on the brain to reduce the satiety, etc. But there is one villain. What is that villain? DP4 enzyme. So what will make the DP4 enzyme? Your active GLP-1 will become inactive. Here the villain is very strong. So by seeing the food, we are producing saliva, we are giving signals to the intestines. Intestines responded. Intestines secreted your GLP and the GIP, but there is one villain. That villain is D4 enzyme, and D4 enzyme will make this active GLP-1 and GIP into inactive. Okay, so this active GLP-1 and how much time it stays in the blood? Only few minutes, 5 minutes, maximum 5 to 10 minutes. So within 5 to 10 minutes, immediately the villain entered and blasted. So, but I want more GLP-1 to be stay in the blood because for the positive effects. So now we have the 2 drugs. One drug attack the villain. So once you attack the villain, what will happen to your heroism? Your hero is GLP-1. So that will stay in the blood for longer period by blocking the villain. That is DP4 enzyme. You have the drugs DP4 enzyme inhibitors. What are they? Gliptins. Okay, and then you have the other type of the drugs, robo, GLP-1 robo. So that means you are introducing the GLP-1 into the body. They almost looks like your GLP-1, but not being destroyed by the, because it is a robo. So what will happen to your blood sugar levels? Will come down because you are staying the GLP for a longer period, because it is not your original GLP-1, it is your robotic GLP-1 which is being introduced externally. So that is the effect of your GLP-1 receptor agonist and D4 inhibitor. I hope I am very clear. So now you have the 2 drugs. One is give the GLP-1 outside, almost behaves like your internal GLP-1. So that is your injectable semaglutide. So otherwise you can use the gliptins, your tenilgliptin or veldagliptin or sitagliptin or saxagliptin or lenagliptin, etc. So they block this DP4 enzyme inhibitor so that your endogenous GLP-1 will be stay in the body for the longer period. That one. Then the pancreas, which cells they have? Alpha and beta. So alpha cells, glucose dependent glucagon production. So reduced glucose production by the liver. So blood glucose will be reduced. On the other ways, beta cells increase more insulin. So obviously they reduce blood sugar. See the benefits of this incretin hormones. Am I clear? So these are the advantages of this. So same thing here. So these are different drugs. So they are not available right now. We are using only last one, semaglutide, once weekly. Okay, no dose adjustments in the renal dosing. You can safely use in the renal failure population. Relation to the meals, not related to the meals. Clinical. See the HbA1c reduction. How much? So it is not very potent like your metformin or the sulfonylureas, but they are very, very vascular friendly drug. They are cardioprotective drug. They are renoprotective drugs. So in all the diabetic individuals, our aim of the medication is to avoid the long-term complications. So in that way, these drugs are very much useful. Produces the weight loss. Is it added benefit in diabetes or not? Yes. Predominantly excreted by the glomerular filtration. All are given as subcutaneous injections. Recently a dual drug has come. There is GLP-1 and GIP also. What is that? Tirzepatide. So advantage, already you all know that advantages. Side effects mainly related to the gastrointestinal system. Nausea, vomiting, headache, tachycardia, pancreatitis. So these drugs should not be given in the people with a past history of the pancreatitis or chronic alcoholics who are more prone for pancreatitis and also thyroid carcinomas, medullary carcinoma of the thyroid. So better to avoid in such individuals. So now the D4 inhibitors. So these are all the gliptins, you know that. These are different drugs. Already I told you the dosages also. But they are oral drugs. Can be administered with or without the food. Used as a monotherapy or in combination with the insulin sensitizing drugs like your metformin, pioglitazone, or insulin secretagogues like your sulfonylureas, or as well as the insulin. Very good drugs. These gliptins can be used with the metformin, with your oglibose, with your sulfonylureas, or with your SGLT inhibitor. Combinations are there. Generally well tolerated. So that's case study. Mr. Y, aged 43 years, detected to have the diabetes on an executive health checkup. Family history of diabetes is present. BP 110 by 70, weight 90 kgs, height 165, BMI 33, fasting 180, postprandial 270, HbA1c 7.8, ketonuria absent. So what is the working diagnosis? With obesity. At this juncture, diabetes. So they mentioned the BP. BP is normal. So they didn't mention the lipids. So get the lipid profile done. But at this juncture, A1C is nearly 8%. Okay. So during a executive health checkup. Okay. So how you treat? The first time detected the values. Once medical nutrition therapy. So from 8% to your goal of 6 or 5% not possible with medical nutrition therapy. So stress upon the diet, exercise, etc. And then use the drugs. See the clear here indication. Executive health checkup. Poorest of the poor, they don't go for the executive health checkup. Executive health checkup means reasonably affordable fellows. So then you can go for good injection semaglutide. Now the cost is also very less. 200, 300, 400 per week is nothing. Per month maybe 1000 to 1200 rupees. Not a big amount. So you can go for the injectable semaglutide. You can start with the metformin. A combination is also advisable. Okay. Or you can straight away go for the SGLT inhibitors with metformin also. SGLT inhibitors plus metformin. Here 73-year-old male, so the respect the age. So here 43-year-old male. Here the 73-year-old male. Here again the gender is also very important, male or the female. Okay, without the previous history of the diabetes. Family history of the diabetes is positive. BP normal. Weight is also normal. Fasting is very high. Postpone is high. HbA1c nearly 9%. So what is the working diagnosis here? Late onset type 2 diabetes. Okay. So with a lean diabetic. So not obese, lean diabetic. Okay. Suppose here ketosis is positive. So what is your diagnosis? Here the last one, HbA1c 8.9, ketonuria absent. Suppose ketonuria present. What is your diagnosis? Type 1 could be possible. So the take home point is type 1 diabetes occurs in less than 20 years for the age group. Majority of the cases. But sometimes it can occur at any age group. Type 1 diabetes can occur at any age group. So even at 73-year-old, I have few people more than 70 years present with the type 1 diabetes. They have the classical 3 Ps and weight loss, ketosis positive, very high blood sugars. The age is 75 years. So it's a type 1 diabetes. So how to clinch the diagnosis? GAD65 antibodies and then C-peptide levels. So C-peptides are very low, GAD65 antibodies are positive. So that shows autoimmune destruction of the pancreas at the age of 70 plus. So treat him as type 1 diabetes only. So start using insulin lifelong. Another 5 years or 10 years or 15 years or 20 years. See, the fasting is very high. Postpone is also very high. HbA1c 8.9. Is there any role of injectable semaglutide? Is there any role of metformin here? Is there a role of sulfonylureas here? There is a role of sulfonylurea here. So because insulin deficiency, so very high blood sugars. So start using the sulfonylurea. So bombarding the beta cells, releasing the insulin. Insulin will reduce the blood sugars very good. And sulfonylureas also will have an added advantage of weight gain. Is lean. So that should be your approach. Okay. Or you can use the gliptins. Gliptins, they also act on the beta cells, on the alpha cells, on the brain, etc. and etc. But don't use the SGLT inhibitors here. Don't use the injectable semaglutide here. Okay. What are the pioglitazone? No, carcinoma bladder, elderly, male. So why should you use pioglitazone? No contraindication. What about the voglibose? No, not only the postprandial. Here see the fasting, very high, 216, almost more than the double fasting. So there is no role of voglibose at this juncture. Voglibose role is there. Fasting is 100, postprandial is 240. Only isolated postprandial hyperglycemia you can add it. So we will move on this SGLT inhibitors. This already I told you. So these drugs. Additional benefits. SGLT inhibitors. Modest weight loss. Used in any stage of the type 2 diabetes. Systolic and the diastolic blood pressure. Improvement all-cause mortality and the CV outcomes. See the heart failures. I told you, no, drug of choice in the heart failure. 4 ways of treating the heart failure. 4 pillars. And heart failure is of 4 types. Rough, PEF, mid-range, and improving rough. What is rough? Heart failure with reduced ejection fraction. EF will be less than 40. What is PEF? Preserved ejection fraction. When the systolic, when EF is more than 50. What is the mid-range? EF is between 40 and 50. What is improving rough? So earlier the rough is, earlier the EF is 30, and after initiation of your therapy, now the ejection fraction is improving. Say 38 or 40 or 42. So that is called improving ref. So there are the 4 grades of your heart failure at this juncture, and most important pillar is SGLT2 inhibitors. Side effects: urinary tract infections, genital infections, etc., and dehydration. Bromocriptine not available. Hydroxychloroquine, I told you, immunomodulatory drug, 200 mg, 300 mg, 400 mg. Saroglitazar, that acts on both alpha and gamma. Okay, both hyperglycemia and hypertriglyceridemia. 4 milligrams OD. Lepaglyn, available in India. Colesevelam, not available. Imiglamin, that is also available. Mitochondrial inhibitor. So that finishes our talk today, and we move on to the next module.